Hello and welcome to the GE Healthcare ISMRM 2021 Symposium. My name is Anya Brau, and I'm the General Manager for MR Clinical Solutions and Research Collaborations at GE MR. I'm very excited today to share with you what's new from GE. And even despite a very challenging year, our team achieved several major accomplishments, delivering new innovations for you, our customers and partners, and for your patients. Then I will turn it over to an excellent set of speakers to expand on these topics. At GE, we have a long history of innovation, beginning with our founder, Thomas Edison, the famous American inventor, who built the first industrial lab to apply organized innovation in pursuit of practical applications. Because it's one thing to invent an idea, and it's another thing entirely to deploy a product into the hands of customers to impact their daily lives. And we've built up over a 100-year track record of delivering valuable products that change the world. And that innovation continues in MR today, with over 35-year history of GE First MRI solutions deployed to impact patient care, many in collaboration with you, our partners around the world. We believe at GE that MR plays a central and growing role in precision health, and that together we unleash the power of SIGNA MR for a healthier world in two main ways. First, by providing MR tools that power clinical excellence and operational value today. And second, tools to advance scientific discovery and translation for a healthier tomorrow, all of which is increasingly improved by artificial intelligence. It starts with great hardware and our lineup of MR systems across the 1.5T and 3T portfolio space. In addition to hardware, our unique, innovative air coils, which are now available across both field strengths 1.5T and 3T, and available in multiple sizes and form factors for different anatomies. These have received excellent customer feedback for patient comfort, ease of use, image quality, and especially versatility when it comes to imaging difficult patient cases. Here on the right, you see examples where only the lightweight, flexible air coil could have been used to perform the exam due to the patient's pain or positioning constraints. And beyond the hardware, we know that the MR workflow today, from order to scan to report, is a fairly complex and tedious process with room for error and inefficiency. And as providers, you're increasingly being asked to do more with less, which generates more process and more data, but not the corresponding tools to simplify and manage your workflow. At GE, what we are building towards is a more streamlined MR workflow of tomorrow that uses AI and digitalization built into each step of the imaging chain to create a more consistent, efficient, and patient-centric imaging. The GE Edison Platform is GE's core AI development and deployment platform for healthcare, developed by the GE Digital team in Silicon Valley, which allows us to develop new AI applications and then deploy them where they make sense in your healthcare workflows, whether that be on-premise, on-device, or in the cloud. And it seems very fitting that this platform is named after our founder, Thomas Edison, for deploying valuable innovations into the hands of customers. And we've been on this Edison journey for a couple of years now, with several examples to show for it, including Imaging Protocol Manager and Imaging Insights to manage operational efficiency in your enterprise. And on the console, AirX for automatic slice plane prescription. But the most exciting example of AI in MR is Recon DL, which we launched last year at ISMRM at 3 Tesla, and which had just received 510K clearance at that time. Recon DL is a novel and unique deep learning-based MR reconstruction that does 3 things. It removes image noise to dramatically improve the SNR. It removes ringing to deliver sharper and clearer images. And these 2 things in turn can be used to enable shorter scan times because you don't need to scan as long to get a beautiful, beautiful, clear image. So you get the best of both worlds, better image quality in less time. And how does it work? Recon DL recognizes the true signal from the noise and uses only the true signals to reconstruct the image. This happens in real time directly at the scanner console to fundamentally improve the image quality. And this reconstructs beautifully clear images. Look at these examples where you see the signal to noise and image sharpness is simultaneously and remarkably improved across each anatomy using Air Recon DL compared to the conventional image reconstruction. We were very proud to partner with 13 global sites for extensive clinical evaluation and testing. And now we're very proud that the commercial product has quickly been adopted and installed all over the world and is running every day with fantastic clinical results. Over 150 sites have installed Air Recon DL, both academic medical centers, community hospitals, and outpatient imaging centers. With 25 abstracts presented at ISMRM and RSNA confirming its clinical use, and 4 published journal articles. Here are examples of Air Recon DL in the lumbar spine, with beautifully clear, high-resolution images acquired in seconds, not minutes, each acquired in 90 seconds or less, for a total exam time of just 4 minutes and 10 seconds. What we've seen is that Air Recon DL encourages users to push the protocol higher than they would have before to very high-resolution protocols, as seen in this image of the great toe at a resolution of 0.3 by 0.3 by 1 millimeter, with amazing image quality. And Air Recon DL also benefits cardiac imaging, which is typically starved for signal to noise due to limited time. And this is now compatible with time course imaging as well as myocardial delayed enhancement, as seen in this very nice dark blood example. So this offers better signal to noise and sharpness for these critical cardiac imaging sequences. And I'm pleased to announce that Air Recon DL is now compatible with diffusion, which is a very important clinical sequence that is also typically signal to noise starved and has a very long acquisition time. But as you see in these examples of diffusion across different organs, signal to noise is improved and sharpness is improved for this important sequence. This is a great example of Air Recon DL in the prostate, where the 3 T2 images are acquired, each in under 90 seconds. The diffusion is acquired in just over 4 minutes, the dynamic lava 8 seconds per phase, and the entire prostate exam can be done in around 10 minutes. This is a remarkable improvement over the standard of care today, with beautiful image quality. And now at ISMRM, we're also pleased to announce the extension of Air Recon DL to 1.5T. So now, in addition to 3T, we offer Air Recon DL across our 1.5T portfolio, including our Explorer, Voyager, and Artist systems. The initial customer sites who used Air Recon DL right out of the box immediately reported shorter exam slots across anatomies. You can see example protocols listed here. For example, Site 1 and Site 2, which were academic hospital sites, reported a 30% reduction in exam times. And the third site, an outpatient imaging center, just under 50% exam time reduction. This yielded increased patient satisfaction, more time for cleaning in between patients, which was very important in this year of COVID, and more productivity with more patients per day. And after we saw these fantastic productivity gains from Air Recon DL, we decided to make it available across the entire GE installed base. So the Air Recon DL revolution continues, and we continue to deploy this innovative technology into the hands of customers and patients in the model of Edison, not just at 3T, but also 1.5T, not just new systems, but existing systems in the install base, no matter how old your system is. Not just fast-spin echo, but all contrast weightings, including now in diffusion imaging. So what's next, you might ask? We plan to continue to develop this technology to benefit all imaging protocols. And senior scientist Mark Labelle, who was intimately involved in this development, will tell you a little bit more about that in the session right after this. And as exciting as this technology is, Air Recon DL is not the only application in our latest SIGNA Air IQ edition. There are a number of new features as well that we encourage you to check out in our booth, including HyperSense 2.0, which is the next generation compressed sensing, AirX Knee for automatic slice prescription in the knee, and Disco and Lava Star, to name just a few. One of the most exciting new applications in this software release is Osteo for MR bone imaging. Osteo is based on ZTE or zero echo time sequences, which allows you to see bone using MR like never before, providing a CT-like contrast that complements the soft tissue information in MR, with a number of interesting use cases in pediatric and orthopedic hip and spine cases. And moving on to our second main aim, which is to advance scientific and discovery by putting next generation MR equipment into the hands of researchers to probe the frontiers of basic science and enable clinical translation, including a number of systems, advanced systems, based on the SIGNA Premier, which is our flagship 3T high gradient system. And many of these advanced systems share many of the components from the SIGNA Premier. First, I'd like to highlight the SIGNA 7T, which we are now proud to announce has FDA clearance in the US. The SIGNA 7T shares the latest hardware and software platforms with the SIGNA Premier to facilitate clinical translation from 7T discovery. It has a powerful gradient, Ultra-G gradient coil, to meet the ultra-high imaging demands for both research and clinical purposes. These are some results from SIGNA 7T showing very high quality, high resolution diffusion at 0.8 millimeter isotropic resolution. These are fMRI results at 7T, fantastic image quality at 1 millimeter isotropic resolution. And what about 7T combined with AirRecon-DL, you might ask? Well, we've combined those two technologies as well. And as you can see here, fantastic signal to noise and clarity when AirRecon-DL is applied to 7T, as seen here in the T2 weighted image, and the amazing detail visible in the fornix. 7T is also cleared for musculoskeletal imaging. And as you see here, some fantastic results in the knee, axial PD fat set and sagittal PD fat set, with beautiful visualization of the cartilage layers in the knee. And we're very pleased to announce that the SIGNA 7T is possible as an upgrade lift to either our existing Discovery MR950 7T scanners or any other vendor's 7T magnet for that matter. We can perform the SIGNA 7T upgrade at your site based on those existing configurations. And the same advanced gradient technology that went into the 7T is also available as an ultra-high performance 3T upgrade on top of our SIGNA Premier technology. This is an example from Stanford University at the CNI Center, and what follows is a presentation by Adam Kerr and Leanne Williams, who will talk about the results from this ultra-high performance 3T system. And finally, the most advanced system at 3T is the Magnus system, which is a brain microstructure imaging system. The Magnus gradient coil can achieve simultaneous 200-500 gradient performance with 3 to 4 times the PNS threshold of previous systems. And this prototype was developed specifically to probe brain microstructure and break through the limitations of whole body systems. This system was funded by a Department of Defense grant and is installed at Walter Reed Medical Center, with several more systems installing over the next 2 years. And on the right, you see amazingly high image quality at very high spatial resolution of 1 millimeter isotropic DTI images at B-value of 4,000. And on the far upper right, B-values of 25,000 at 2 millimeter isotropic. Amazing image quality achieved with this very efficient, very high-powered gradient coil. And I'd like to conclude by mentioning that we have a very active MR collaboration community to support the innovative activities of our user base. We have a number of online forums and SIGNA community groups revolving around central topic areas such as neuro, C13, 7T, PETMR. Of course, usually meeting and gathering in person, but over the last years have gotten quite active with an online community. For example, our GE Connectome working group. And this community has launched several multi-site studies over the last few years. We believe that open access and open communication accelerates innovation, and we are pleased to invite you to join our community. And with that, I'd like to turn to the set of speakers we've invited for the second half of our session. A very exciting lineup, beginning with Mark LaBelle, who is a senior scientist at GE, and he was very closely involved in the development of Air Recon DL and will share with you the scientist perspective on this new technology. He'll be followed by Dr. Mirko Cosentini from University of Pisa, and he will speak about neurodegenerative disease on their SIGNA 17. And finally, Dr. Adam Kerr and Dr. Leanne Williams together will present their latest results on psychiatric disorders imaged using the Connectome protocol on GE's Ultra High Performance 3T, the first of its kind. So now I'd like to introduce Mark LaBelle, a senior scientist in our team, to talk about Air Recon DL, a scientist's perspective.
Hello, I'm Mark LaBelle. I'm a scientist with GE Healthcare and one of the developers of Air Recon DL. This is a feature that we're really excited about because we know it has a huge impact on image quality. And I'm here today to tell you about why Air Recon DL works so well. And Air Recon DL is really arose from the desire to make the best images an MR system can provide. And we've made great progress with gradients and aircoils. And Air Recon DL represents the innovation in the reconstruction pipeline. To start off understanding what Air Recon DL does, let's take a look at a simplified image reconstruction pipeline. If we start with a high resolution object, in this case, just our digital Shep-Logan phantom, and we sample the data, we end up with a truncated K-space sampling where we haven't acquired all the high spatial frequency components, and it's noisy. The inverse Fourier transform produces an image, but we can see truncation artifact throughout, which is the ringing near all the edges. The image is rather pixelated, and it's fairly noisy as well. A typical solution would be to provide an apodization filter, which would be some sort of smoothing filter in the image, and also to interpolate the image, which can be achieved with zero padding in K-space. The problem here is that a reconstructed image, it still shows ringing, is now blurrier, and it still has noise in it. So this is not a perfect solution. And a few of the observations from this reconstruction are that we've made an assumption that the high spatial frequencies are all zeros. We've discarded valid data that we worked hard to acquire, and we've also ignored some of the noise throughout K-space. So really, from this simple reconstruction, we know that we can do a lot more with what we have. And now this provides a lot of potential opportunity in clinical protocols, which are typically resolution and SNR limited. They're not necessarily acceleration limited. So if you look at this typical T1 FLAIR protocol, we can see that it uses a relatively thick 4mm slice. It uses 2 averages and has no acceleration. And although the scan time at 2.5 minutes is fairly reasonable, there's a lot of opportunity to improve this type of protocol. What we have to do is make the most of the data. So we have to achieve the best resolution possible for the data that we've acquired and minimize the noise to produce the cleanest possible image. And by doing this, this will let us push our existing technologies, like higher performance gradients to get thinner slices or higher bandwidth. We can achieve higher acceleration factors that are enabled by our aircoils, or even just simply acquire fewer averages to make protocols like this much better. We'll get better image quality and potentially shorter scan times. What we've really come up with is an AI-embedded image reconstruction pipeline that will make the most of the data that we have. So we've developed proprietary AI algorithms that do 3 things. They remove ringing, noise, and they interpolate images. And you can see that from these images on the right. The conventional reconstruction in the image, we can see ringing around all the edges. You can see from those orange arrows, there's truncation artifact around those edges, and we have noise throughout the image. The corresponding K-space, you can see is noisy, and you can see the domain where we've acquired data, and that where we've assumed zeros, which are probably wrong for interpolating the image. The image on the right is showing the output from Air Recon DL, where that ringing is essentially gone, as shown by the green arrows, and the image is very clean and with the noise essentially gone as well. The corresponding Fourier domain shows that the K-space center that we've acquired is cleaner, but also we've made an estimate of the data that's needed to support the acquired data to get rid of all the ringing in the image. A really important component of this reconstruction is that we use deep convolutional neural networks, or CNNs, that are embedded in the reconstruction pipeline. So they operate on complex valued floating point data directly. This is particularly important for the noise reduction component, where we want to reduce noise in the complex data to remove the bias and the magnitude images. So you can see that here in the bottom, where we have complex noise distributed in the real and imaginary components. which when you view a magnitude image, produces a non-zero mean noise distribution. This is problematic because that non-zero mean looks a lot like the signal. So they're very correlated and difficult to remove. What we need to do is we need to reduce the amount of complex valued noise in order to reduce the bias and reduce the width of the noise in the images. So a reconstruction integrated solution is the right way to do this. And convolutional neural networks are very effective at isolating noise with known and simple distributions like complex Gaussian noise. An advantage of CNNs as well is that they're able to separate the noise from the signal without unnecessarily blurring out the image. A really innovative part of AReconDL is how it does the ringing reduction. We've historically considered ringing, or Gibbs ringing, to be an artifact to be removed. But in truth, it's actually an indication of subvoxel information. It's really a clue about the edge location. So rather than fighting with the ringing, what we can do is we can use that ringing to really help interpolate the image by having a better estimate of where those edges are. And you can see that in the line profiles. The blue and the red for conventional and AReconDL show that AReconDL is not only reducing the ringing around the edges, but it's actually giving you a sharper transition. It's giving you a sharper edge. And this is because we are actually removing the ringing, that we're able to provide a good interpolated high resolution sharp image. When we put this all together, what we get is an AI embedded image reconstruction pipeline. The conventional pipeline has multiple elements in it, including many of the familiar elements like Fourier transforms, parallel imaging modules. But what we've done is we've now embedded these and supported them with convolutional neural networks. So we're really augmenting and assisting these proven reconstruction technologies that we know and we trust and we understand. Another benefit of this implementation is that images are reconstructed immediately and on device. Once we put this all together for the first time, our initial prototype produced images that were really interesting to look at. In fact, they were noise-free images, which is something we didn't really understand what this meant. And you can see that it does some really promising things, and that it's removing the artifacts in the chord. The Gibbs ringing is gone, the noise is gone, shown by those red arrows. And it's keeping the subtle structures, shown by the green arrows on the right. In fact, those subtle structures are preserved, in fact, often improved. The problem is that radiologists, and actually really everybody, was uncomfortable looking at these images, partly because of familiarity. We don't know what a noise-free image means, but also because noise is used to assess the certainty when evaluating an image. This meant that we went back and redesigned the image reconstruction. And what we ended up with was the ability to provide a tunable noise reduction, so that we can independently modulate the noise reduction from the ringing and interpolation. So from the raw image on the left, we're able to provide different settings, for example, low, medium, and high, where the noise is being selectively removed, but the ringing is always there. To train this network, what we've done is we've used a supervised learning approach, where we have pairs of clean, high-resolution images and noisy, low-resolution images. Fortunately, we have access to a very large training database, and following simple augmentations, we never have to reuse the same training data more than once. The result is that our training is very well behaved, and you can see that the objective function here, which we want to minimize as a function of the number of training steps that we've used, the number of training images, has a couple of nice features. The first is that it decreases monotonically, which means that we are not seeing evidence of overfitting. And this is because we have so much data to use. The other is that we have a stable convergence to what is essentially the minimum loss at the end of training. Because we have so many images and so many diverse images and different levels of noise, we're able to provide really excellent generalizability. So we're able to apply this now to all anatomies, contrast weightings, coil configurations, field strengths. There's really no major restriction to how we want to apply this. So it works on things like heads and shoulders, knees and toes. I was tempted to sing, but I've chosen not to, so you're welcome. But it also applies to different contrast weightings like PD, T1, T2s. There's really no limit to how we can apply this. We've spent a lot of effort characterizing the performance of AReconDL and demonstrated that it has a very expected SNR behavior. So when we look at the signal-to-noise ratio as a function of the number of averages in the image, you can see that the original and AReconDL all follow an SNR increase that behaves with a root scan time. The other is that the signal-to-noise ratio increases with the user-specified denoising level. So as we increase the AReconDL level, the SNR goes up. And this gives us two ways to use AReconDL. The first is shown with these orange dotted lines, the images on the right, top right. is to keep the same scan time and achieve a higher signal-to-noise ratio. So the same amount of scan time, the signal-to-noise goes up and the image looks cleaner. The red arrows show where the ring is being reduced throughout with the AirRecon DL images. We can also use this to reduce the scan time while achieving a similar signal-to-noise ratio. So on the bottom, the red dashed line is showing images that have 15 averages without AirRecon DL, all the way down to 1 average with AirRecon DL. The SNR is about the same, but ringing is still reduced. We were very concerned about what could be lost when using AirRecon DL, so we performed several low-contrast detectability studies, one of which is a human reader study with a digital reference object. This object consisted of a series of disks of different sizes in contrast to noise ratios. And the reader was asked to indicate which disks were visible in a particular case. And after multiple noise realizations, we quantified the detectability and found that AirRecon DL did 2 things. The first is that it was able to provide better detectability in the large disks, and that's shown by the red on the bottom plot, the red and yellows. But it also didn't impact the single point detectability. Single point detectability essentially remained unchanged and was limited by the Rose criterion, which required a contrast to noise ratio of at least 5 for reliable detection with or without AirRecon DL. The implications here being that we don't believe there's any missing information that a human reader would be able to detect. And also, because of the improved detectability in some cases, it's translating to easier and more consistent reads. I'd like to highlight a couple of peer-reviewed publications. The first is from MD Anderson, that's showing that AirRecon DL without an endorectocoil provides cleaner and sharper images than a conventional reconstruction with an endorectocoil. So lesions in the prostate are actually more clearly visualized with AirRecon DL and without an endorectocoil. The second is from our collaborators in Erasmus, who found that late gadolinium-enhanced myocardium images were actually improved with AirRecon DL. And that's seen by the bar plot with more orange and yellow than with a conventional reconstruction. The last publication was showing that thin slices could be used to improve pituitary imaging. And our collaborators in Korea showed that by changing their protocol from a 3 millimeter slice thickness to a 1 millimeter slice with only a marginal increase in scan time, the diagnosis was completely different in that they were able to see residual tumor adjacent to the carotid arteries with their improved protocol with AirRecon DL. So this is actually making a difference in the detection and the diagnosis of this patient. So what's coming up next? We are actively working on bringing 3D. So we're aiming to provide higher SNR images and sharper images with no ringing in all 3 dimensions. In fact, we have our first abstract using this technique being shown at this ISMRM. There's a talk on Thursday that you can please go check out if you want to see some of these images. We're also working on Propeller, so we can get motion insensitive 2D imaging with the benefits of AirRecon DL. And we have 2 posters on this on Wednesday. So just to conclude, this has been an absolutely amazing project that I've enjoyed working on. I'm based at the University of Calgary in Canada, but it's been a great pleasure to work with my GE collaborators throughout the world and our academic partners who've helped evaluate this and helped us bring this to market. And it's been an absolute pleasure to see this being distributed globally and installed and getting some of the initial feedback. So thank you very much for your attention.
Great. Thank you so much, Mark, for taking us through the story of AirRecon DL and its evolution. Next, we want to turn our attention to 7T, and I'd like to introduce Dr. Mirko Cosentini, who's an associate professor of neuroradiology from the University of Pisa. He'll speak about neurodegenerative disease at 7T.
Dear colleagues, welcome to this GE Symposium. My name is Mirko Cosentini, and I'm a neuroradiologist of the University of Pisa in Italy. My talk today is about our experience in applying ultra-high magnetic field strength MR imaging in neurodegenerative disease. In Pisa, we installed a 7T GE MR system in 2012. It was the first GE system installed in Europe and the only magnet at 7T in Italy. At the time of the installation, the magnet had a research purpose only. But today, the 7T is approaching to become a clinical tool. The potential advantages of the ultra-high magnetic field strength are based on physical properties that allow to obtain an extreme high resolution due to the increased signal-to-noise ratio. Moreover, the higher sensitivity to susceptibility phenomena allow to obtain new types of contrast. In this image, you can appreciate the extraordinary in plane resolution in the order of 120 microns. The reason why we approach neurodegenerative disease with the 7T is twofold. The first one was to discover a 7T MR biomarker of pathology of the disease for which conventional magnetic field strength have no positive predicted value. In other words, to apply 7T in pathologies where the conventional MR is negative. The second reason was to reveal an MR feature at 7T that can be used for a diagnosis at a single subject level. We start our experience at 7T evaluating the normal anatomy. With appropriate techniques such as this cutting box, we can obtain section of ex vivo samples that correspond exactly to the section obtained with the MR acquisition. In this slide, by using our magnet for humans and a dedicated customized coil, we built a cutting box for the brainstem. And you can appreciate the perfect overlaying of the MR images with the histological sections obtained with a cryotome. Please note the wide metal fiber bundles that are visible with the Luxol fast blue staining that are well detectable also in this proton density image. In neurodegenerative disorder, we decided to explore the anatomy of structure that a priori we know to be affected by a pathological process. Alzheimer's disease is the most frequent cause of dementia, and in this image I show you the target of the pathological process, that is the hippocampal formation in an ex vivo sample. In comparison with histological staining, you can see the hippocampal subfield with the pyramidal layer and its apical neuropilum that constitute the stratus lacunosum molecolare, that is this thin hypointense line. We know that Alzheimer's disease is a continuum process that is clinically unveiled with the appearance of mild cognitive impairment or symptoms of dementia. But we know that it starts several years before with the preclinical phase. Recently, NIA criteria for a biomarker-based definition of Alzheimer's state that the markers of beta amyloidopathy and tau pathology can be measured from the CSF, but the marker of neurodegeneration remains the atrophy measurement with MR. In this image, I reported the 3D acquisition with the 600 micron isotropic resolution obtained by the EOFIND International Consortium, that the increased resolution allowed by 7T acquisition better estimate the brain atrophy and its relationship with the cognitive impairment in Alzheimer's disease. However, we know that the atrophy occurs in the late phase of the Alzheimer's disease when MCI or dementia are ongoing. A radiological marker of the preclinical phase of Alzheimer's would be advisable, and we know that the earliest phases of neurodegeneration is characterized by the loss of neuropilum. Manual or automatic measurements of the stratum radiatum and lacunosum molecolare demonstrate a reduction of its thickness correlating with the neuropsychological tests in both Alzheimer's disease and mild cognitive impairment. Parkinson's disease is a disorder of the motor system characterized by tremor, stiffness, and bradykinesia. As discussed before, in neurodegenerative disorder, there is a symptomatic phase preceded also by several years by pre-symptomatic period. In this prodromic condition, a therapeutic option could modify the course of the disease. And this is the reason why we try to identify early diagnostic biomarker. The pathological hallmark of Parkinson is the loss of dopaminergic neuron in the substantia nigra. Notwithstanding many attempts in distinguishing the different components of the substantia nigra, they cannot be differentiated with conventional or advanced MR sequences. We start our experience in Parkinson at 7T by evaluating the normal anatomy of the substantia nigra, and we are able to detect its inner structure with a three-layer organization. Within the intermediate layer, there is a novel-shaped hyperintensity that has been demonstrated to correspond to nigrosome 1 formation, a Calbinding negative structure containing dopaminergic neurons. The in vivo acquisition allow to identify the trilaminar structure of the substantia nigra and also the nigrosome. In patients with Parkinson's disease, the targeted iron-sensitive images demonstrated the loss of the normal anatomy and the loss of nigrosome with a diagnostic accuracy of 96%. The ongoing research is about the role of substantia nigra imaging as a prognostic biomarker in subjects at risk to develop Parkinson, and also in about 60% of subjects with REM behavior disorder, that is a parasomnia that has a high rate of conversion to Parkinson along the time. MR have an important role in the differential diagnosis with atypical Parkinsonism. You can see the atrophy and the abnormal hypointensity of the putaminal nuclei in a patient with multisystem atrophy. Nevertheless, the sensitivity of MR is low due to the late appearance of radiological signs that reflect the gross pathology. Several authors suggest that to increase the diagnostic accuracy, we need of a technique that is able to detect the microscopic abnormalities before the macroscopic changes occurrence. And quantitative susceptibility mapping, QSM, is a technique that allows to estimate the iron content by measuring the susceptibility. We revealed increased susceptibility in red nuclei of patients with progressive supranuclear palsy and in putamina of patients with multisystem atrophy, indicating that the QSM could be used as a probe to explore the microscopic changes within the basal ganglia of patients with atypical Parkinsonism. The last neurodegenerative disorder that we evaluated, 7T, is the amyotrophical lateral sclerosis. It is a motor neurodegenerative disease characterized by degeneration of lower and upper motor neurons. Morphometric, functional, and structural changes in the primary motor cortex can be explored with advanced MR technique. But the main problem is that this technique explores the pathologic process at group level and not at the level of single subject. As well for Alzheimer's and Parkinson, we start our studies with the evaluation of the normal anatomy. Differently from conventional MR, the 7T MR allows to recognize within the cerebral cortex a superficial hyperintense layer component corresponding to the cytoarchitectural layers 1 and 3, and a deep component, more hypointense, that correspond to layer 5 and 6. We know that in patients with amyotrophic lateral sclerosis, the neuronal loss in the 5th layer of the primary motor cortex is linked to an infiltration of the microglia, a type of cell that is rich in iron, as demonstrated in ex vivo specimen. By exploring in vivo the cerebral cortex of patients with amyotrophic lateral sclerosis, we demonstrated the presence of a band of a signal hypointensity with a track appearance in the deeper layers of the cerebral cortex, with a sparing of the more superficial layer. QSM, we are able to estimate the iron content of the cortex in amyotrophic lateral sclerosis patients. That is significantly higher than in healthy subjects, and in particular, the susceptibility reaches the highest value in the group of patients with upper motor neuron impairment, a value that correlates with the upper motor neuron impairment measured with proper clinical score. The hypointensity of the deep layers of the primary motor cortex has a precise anatomofunctional relationship. In this 7T fMRI study, we are able to map the somatotopic positions of the different bulbar function, such as swallowing, vocalization, lip movements, and so on. In patients with both arms and bulbar function impairment, the signal hypointensity, in orange, involves the entire primary motor cortex. In blue are shown the cortical signal changes of patients without bulbar symptoms that spare the lower portion of the primary motor cortex where the bulbar functions are represented. This indicated that the microglia accumulation co-localized with the impaired functional area. In conclusion, 7TMR has demonstrated great potential in investigating neuropathological processes on single subjects affected by neurodegenerative disorders. 7T can be considered a promising tool for the identification of imaging-based biomarkers in several neurodegenerative disorders. I would like to thank a lot of colleagues, collaborators, and friends that allowed the realization of this work and that walked with me along the road of this extraordinary 7T adventure. Thanks for your attention and have you a good lunch.
Thank you very much, Mirko, for that presentation. Thank you for joining us at GE Healthcare's ISMRM Symposium. We look forward to continuing the conversation with you on AirRecon DL and other GE innovations and system configurations at our ISMRM booth. Please visit our exhibitor page to learn more. And thank you so much for joining us.